Welcome back, students, to part 126 of our masterclass. Today, we are diving straight into the extremely high-stakes world of ECMO, cannulation, mechanics, and duration rules. Now, in part 125, we laid the groundwork with tracheostomies and organ transplants. But today, we're taking things to a whole new level. We are looking at literally the highest acuity cases you will ever encounter as a medical coder or CDI specialist. It's intense, it's complex, and it is absolutely crucial to get right.
But before we unravel the intense mechanics of extracorporeal life support, I've got a quick favor to ask. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
Okay, let's look at our roadmap for today. We're going to break down how ECMO fits into pre-MDC grouping logic, untangle the clinical mechanics of VV versus VA ECMO, drill down into exact ICD-10 PCS coding precision, and finally, arm you with the strategies you need for rock-solid audit defense. Let's get right into it.
Starting off with part 1, we're zooming out to look at the macro level. How exactly do these massive, resource-intensive procedures group into the highest-paying MSDRG tiers? Well, to master the coding, we really have to grasp the clinical reality first, right? Extracorporeal membrane oxygenation, or ECMO, is nothing short of incredible. Blood is physically pumped outside the patient's body into a heart-lung machine. This machine then takes over. It scrubs out the carbon dioxide and pumps perfectly oxygenated blood back into the tissues. Because a patient on this level of life support is so critically ill, ECMO is granted global pre-MDC precedence. Basically, it has the raw power to completely override all other organ system MDCs to dictate that final DRG assignment. Now, the Medicare's severity DRG system splits this massive level of care into two very distinct tiers. If a patient is placed on ECMO, or if they have a tracheostomy with mechanical ventilation going for more than 96 hours, they're going to group to either MSDRG 003 or 004. So what's the dividing line? It all comes down to the presence of a major operating room procedure. If they have one, boom, they group to 003, which carries an exceptionally high relative weight. If they don't, they drop down to 004. Grasping this split is an absolute game changer for your hospital's reimbursement accuracy. Moving on to part 2, let's step away from the grouping logic for a second and walk right into the ICU. We need to talk about the actual bedside clinical mechanics. When you're combing through a chart, you're primarily going to see two modalities of ECMO, veno-venous and veno-arterial. Veno-venous, or VV ECMO, is strictly for isolated, severe, acute hypoxemic respiratory failure. We're talking refractory ARDS or severe viral pneumonia. The circuit drains the venous blood, oxygenates it, and sends it straight back to the venous system. It's only supporting the lungs. But then we have veno-arterial, or VA ECMO. This is used for refractory cardiogenic shock or massive pulmonary embolisms. With VA, the blood is pumped back under pressure into the arterial system, so it's providing full biventricular cardiac and respiratory support. It is a total cardiopulmonary takeover. Now, along with the type of ECMO, you absolutely must know how the physicians actually cannulated the patient. Why? Because this entirely dictates your ICD-10 PCS approach characters. Central, open chest cannulation usually involves a full sternotomy or thoracotomy. On the flip side, a peripheral, percutaneous approach usually means they're going in through the femoral or internal jugular veins. As a coder, you have to play detective here. Meticulously read that operative report so you can accurately choose between an open approach, which is character 0, or a percutaneous approach, which is character 3. Okay, part 3. Let's take all of that complex clinical knowledge we just covered and translate it directly into surgical ICD-10 PCS coding precision. Let's actually build one of these codes together. We're going to construct the exact 7-character code for continuous respiratory ventilation that lasts greater than 96 hours. We kick things off in section 5 for extracorporeal assistance and performance. Our second character, the physiological system, is A. The third character, the root operation, is 1 for performance. The fourth character, body system, is 9 for respiratory. Then our fifth character dictates duration, so we choose 3 for greater than 96 hours. The sixth character, function, is 5 for ventilation, and we wrap it up with Z for no qualifier. Put it all together and you've perfectly constructed 5A1935Z. Now, I want to pause on a really crucial point here. Why did we choose performance as our root operation instead of assistance? Well, the PCS guidelines are very specific. Performance means completely taking over a physiological function by extracorporeal means. An ECMO machine or a continuous mechanical ventilator isn't just giving the patient a little help. It is doing the entire job of breathing for them. Assistance, on the other hand, is when you're only taking over a portion of that function, kind of like a CPAP machine. Getting this distinction right is non-negotiable.
And when you are using these performance codes, exact duration tracking is your best friend. The golden rule for mechanical ventilation is this: the exact time of intubation is your heart start time, and extubation is your hard stop time. That duration entirely dictates your fifth character. Is it less than 24 hours, 24 to 96, or greater than 96? Honestly, failing to calculate this down to the exact hour is how cases accidentally fall out of MSDRG 003 or 004 entirely. And that is a massive hit to the hospital's revenue. But here is a huge warning. Coding the extracorporeal machine's runtime is really only half the battle. The actual procedure for placing the cannulas requires its very own entirely separate procedure code. If a surgeon performs an open bypass or a percutaneous vascular access procedure just to hook the patient up to the ECMO circuit, you can't stay in Section 5. You have to navigate over to the medical and surgical section, usually Section 021 for heart and great vessels, to accurately capture the approach and device placement. Do not miss that step. Moving right along to Part 4, Audit Defense and Clinical Documentation Integrity. Once you've got the coding right, how do you protect that revenue and ensure the clinical truth survives an intense auditor review? Because these ECMO cases represent the most critically ill patients in the entire hospital, you better believe auditors are going to aggressively target them. So you have to be relentless about capturing secondary diagnoses, those CCs and MCCs. Be on high alert for things like ECMO-induced coagulopathy, severe post-cannulation hemorrhage, or acute kidney injury that requires continuous renal replacement therapy, known as CRT. And of course, keep a sharp eye out for sepsis or septic shock. These secondary diagnoses drastically shift the DRG weight and paint the true clinical picture of the patient's fight for survival. But listen, just capturing the diagnosis is not enough. Timing is literally everything. The present on admission, or POA indicator, is a strict gatekeeper here. Think about it. If a patient is admitted and they develop sepsis 2 days later, that POA indicator is an N for not present on admission. And because of CMS rules, that means it cannot be used to boost the DRG payment, even though sepsis is a major complication. This is exactly why CDI specialists have to query physicians immediately to establish precisely what was present the second that patient walked through the doors. To truly bulletproof your ECMO claims against those frustrating payer denials, your documentation has to be flawless. You need to systematically review the respiratory therapy logs and the perfusion continuous runtime logs. You also have to verify medical necessity using the physician's exact wording, making sure those cannulation operative reports perfectly match your billed approach. And critically, you have to differentiate between true ECMO for severe failure versus just routine cardiopulmonary bypass used temporarily during a scheduled open heart surgery. They're absolutely not the same thing, and mixing them up is an automatic denial. All right, we've reached Part 5. Let's pull all of these threads together and summarize the critical takeaways from today's deep dive. If you remember nothing else, remember this. ECMO is a powerhouse that overrides standard MDCs. You absolutely must understand the clinical difference between veno-venous respiratory support and veno-arterial cardiac support. When you are in ICD-10 PCS Section 5A1, microscopic precision is required. You have to track ventilation and ECMO duration to the exact hour. And finally, secure those severe secondary CC and MCC diagnoses with accurate POA indicators so your charts are fully audit compliant.
Now, looking ahead, you definitely will not want to miss our next explainer. We are going to continue our pre-MDI deep dive by unpacking the complex DRG logic for solid organ transplants, covering heart, lung, liver, and kidney replacements. It's going to be packed with essential insights. Before we wrap up, let me remind you, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
I want to leave you with this final provocative thought. As a coding professional or CDI specialist, you are the ultimate defender of the clinical truth. So ask yourself, if a payer decides to audit your 5A1935Z case tomorrow morning, demanding proof for that highest paying DRG, will your chart documentation hold up to the exact hour? Think about it. See you next time.